areas in IVH as brief as and as inshallah we'll be fast to cover this area. So the objectives is to define the IVH, to describe the epidemiology of IVH, to determine the risk factor of IVH, to understand the pathophysiology and pathogenesis of IVH, to know the degree or the grades of IVH, to know the sequelae of high grade of IVH, to know the IVH bundle of care, and to be able to identify practice in intraventricular hemorrhage prevention in neonates. So what is the germinal matrix intraventricular hemorrhage? It is a complication of premature delivery that can result in lifelong medical and developmental consequences. IVH is a bleeding that originates in preventricular subepididymal germinal matrix with subsequent entrance of blood into the ventricular system of the brain. How big is the problem? IVH remains a serious problem despite relatively recent decreases in the incidence because of increased survival of extreme low birth weight infants less than 1 kg, as well as the severity of sequelae. The most common CNS complication of preterm, the sequelae and outcome of IVH, which is post-hemorrhagic hydrocephalus, preventricular leukomalacia, seizures, cerebral palsy, and mental retardation. Epidemiology, the incidence and severity is inversely proportionate to gestational age and birth weight. IVH occur 25 to 30% of very low birth weight, and nationally 15% of all very low birth weights have grade 3 to 4 IVH. Timing of IVH, almost 50% occur by 24 hours of life, 80% by 48 hours of life, 90% occur by 72 hours of life. By 7 days of life, 99.5% have occurred. 20 to 40% have hemorrhagic progression over 3 to 5 days. So what are the major risk factors for IVH? Risk factor, we have intrapartum factor and neonatal factor. Intrapartum factor related to maternal transport, neonatal transport, mode of delivery, cesarean, vaginal, vacuum-assisted delivery, delayed cord clamping, and birth asphyxia. Neonatal factor, prematurity is the most important risk factor for IVH. Rapid volume expansion, for example, the correction of hypotension with volume infusions, asynchrony between mechanically delivered and spontaneously breathed in infant on ventilation, if the baby ventilated, and we should be aware about asynchronicity between the mechanically delivered and spontaneous breath, and we will explain later this in the pathogenesis. Hypertension or beat-to-beat variability of blood pressure, hypoxic ischemic insult, respiratory disturbances like hypercarbia, hypocarbia, pneumothorax, auto-regulation, we will explain this later. Infusion of hypertonic solution like sodium bicarbonate, which is lead to rapid volume expansion. Frequent handling, tracheal suction, hypovolemia, hypotension, hypoglycemia, sepsis, coagulopathies, and anemia. Now we will talk fast for pathogenesis. I will not go for anatomical and pathophysiology. I will go directly. Thought to be caused by capillary bleeding due to immature germinal matrix is highly vascularized by fragile microvessels. Two major factors that contribute to the development of IVH, which is first one, loss of cerebral autoregulation and abrupt alternation in cerebral blood flow and pressure. Healthy infants who were born prematurely have some ability to regulate cerebral blood flow through the process called autoregulation. However, autoregulation is lost under some circumstances and frequently compromised in very premature infants with pulmonary disease. The alternation from autoregulation to pressure passive circulation pattern appear to be an important step in the development of IVH. When a pressure passive circulatory pattern is challenged with the fluctuation of cerebral blood flow and pressure, hemorrhage can occur. The systemic blood pressure becomes the primary will be depend on the systemic blood pressure instead of autoregulation, the normal autoregulation. In this state, any condition that affects systemic blood pressure and specifically rapid alternation in blood pressure can result in IVH. The capillaries of the immature germinal matrix process neither tight junction between the endothelial cells nor strong basement membrane, therefore increased flow and pressure may be rupture the delicate capillaries, leading to bleeding. Patients without asynchrony between mechanical ventilation and patient efforts, disregarding the babies who was under ventilation, had stable blood pressure, stable cerebral perfusion, and lower incidence of hemorrhage. The use of term periventricular hemorrhagic infarction is preferred over the term grade 4 hemorrhage. The use of this terminology stresses the current theory that periventricular hemorrhagic infarction is a complication of lower grade hemorrhage rather than more severe versions, same pathophysiological event. This means this can grade 4 happen after grade 1 even or grade 2. It is not sequentially grade 1, 2, 3, then 4. So better to call it as periventricular hemorrhagic infarction. So now we will go to IVH staging or grading. We have two common systems, which is Volpi and Papil grading system. There is comparison here between both of them. And we have 4 grade 1, 2, 3, 4 in papillary criteria, unilateral or bilateral germinal matrix hemorrhage, then grade 2 IVH without ventricular dilatation, grade 3 IVH with ventricular dilatation, and grade 4 IVH extended to adjacent parenchyma. Volpi criteria, grade 1 germinal matrix hemorrhage with no IVH or IVH occupying less than 10% of ventricular area. Grade 2 IVH occupying 10 to 50% of ventricular area. Grade 3 occupying 50% and plus minus periventricular echo densities. Grade 4 periventricular venous hemorrhagic infarction, cystic periventricular decomalacia. Here, almost same, their explanation for the here in the grade 1, there is only the subependymal germinal matrix bleeding. The ventricular system appear normal, not dilated. In grade 2, the increasing the bleeding in the lateral ventricles, which is occupying less than 50%. Then grade 4, it will be more than 50% of ventricular system with or without ventricular dilatation. In grade 4, it will start to have extensive intraventricular hemorrhage with ventricular dilatation, with parenchymal venous infarction. Here, their ultrasonographic staging, same grade 1 only here in the ventricular base. Grade 2, it's occupying the hemorrhage less than 50% of the ventricles. Grade 3, it will be associated with ventricular dilatation, and grade 4, it will have like decomalacia and change in the parenchyma. Clinical one subgroup of infant with IVH present with the following: sudden unexplained drop in hematocrit levels, possible physical finding related to anemia, for example, pallor, poor perfusion, or hemorrhagic shock. Another subgroup of infant with IVH present with extreme sign, including the following: sudden or significant clinical deterioration associated with anemia, metabolic acidosis, glucose instability, respiratory acidosis, apnea, hypotonia, seizures, hypotension. Between the two extremes of presentation, infant may demonstrate varied degrees of neurological and systemic signs. Workup and diagnosis. Bedside cranial ultrasound, the diagnostic tool of choice for screening, examination, and follow-up of individuals with IVH. Current recommendations by quality standards subcommittees of the American Academy of Neurology suggest that all infants younger than 30 weeks gestation be screened by cranial ultrasonographic at 7 and 14 days of postnatal life and at 36 to 40 weeks for post-menstrual age. Serial ultrasonography is indicated weekly to follow for progression of hemorrhagic and development of post-hemorrhagic hydrocephalus. Serial daily measurement of fronto-occipital head circumferences should be performed, especially if the baby's initial screening showing IVH. Medical care, general supportive care, correction of underlying medical disturbances, as well as cardiovascular, respiratory, and neurological support. Such measures include the following: correction of anemia, acidosis, hypotension, as well as ventilatory support. Serial lumbar puncture is not indicated, although it was once used to prevent progression of hydrocephalus. Long-term monitoring include neurologic and developmental follow-up. So what's the major sequelae of IVH? The first one is post-hemorrhagic hydrocephalus. I will not talk about this in detail, just to mention the mechanism by which hydrocephalus developed. It is decreased the absorption of cerebral CSF, secondary to obstruction of arachnoid villi by blood and debris of the development. So it will be communicating hydrocephalus. And the other types is obstruction of CSF circulation, obstructed hydrocephalus. Second sequelae, preventricular leukomalacia. This disorder of preventricular white matter following IVH attributed to profound and long-lasting decrease in CSF. Preventricular leukomalacia may progress to proencephaly, may lead to spastic dysplasia, visual defect, or cognitive impairment. Other sequelae like cerebral palsy, mental retardation, and seizures. The prognosis depend on the grade. So grade 1 and grade 2 hemorrhage, the neurodevelopment prognosis is excellent. Grade 3 without white matter disease, mortality less than 10%, and 30 to 40% have subsequent cognitive or motor disorders. Grade 4 or beta to periventricular hemorrhagic infarction, mortality approach to 80% of infants, and 90% incidence severe neurological sequelae include cognitive and motor disturbances in those babies. Prevention, antenatal steroids and prevention of prematurity are important elements in the prevention of preventricular hemorrhage and intraventricular hemorrhage. Avoidance of conditions that do the following, which is interfere with autoregulation, hypocarbia, hypercarbia, hypoxia, acidosis, overwhelm autoregulation abilities, for example, hypertension, contribute to rapid fluctuation of cerebral blood flow, for example, ventilatory asynchrony, rapid volume expansion, noxious stimuli, frequent handling. The use of other pharmacologic modalities to prevent IVH has been proposed. However, this use is not widely accepted. The other pharmacological modalities include prenatal treatment with vitamin K, phenobarbital, postnatal treatment with ethamycelates, phenobarbital, and vitamin A. Although post-report concern the efficacy of this agent are noted, further investigation is required to prove the conclusive evidence of benefit. Also, indomethacin has been shown to decrease the risk of high-grade intraventricular IVH. However, development of outcome have not been shown to be improved with the use of indomethacin prophylaxis. For this reason, the role of indomethacin in the prevention of IVH remains for prevention intraventricular hemorrhage in preterm infants. This is what we are using in Qassimi Women's Children's Hospital in our ICU. This is the criteria we are applying to the babies less than 30 weeks, less than 1 kg for the first 3 days to reduce the handling for the baby. Head aligned midline with no prone position. Tilt of the bed is a 30-degree, avoidance of head down position, sudden elevation of leg or diaper change, avoid rapid arterial venous flush and rapid arterial withdrawal of blood, fluid bolus over not less than 60 minutes, unless the patient is in shock state. Normal signs and parameters: skin temperature 36 to 37 degree, blood pressure less than 95 percentile to avoid hypertension, CO2 level 45 to 59, clustered care, minimal handling, inclusive radiological assessment, gentle care maintaining, no bath is given, sound level kept less than 45, and light are demand unless very necessary, blender kept on all the time, pre-medication given before intubation, pain management aiming for NIPS score for less than or equal to 1, UAC UVC recommended for newborn, weight less than or equal 1 kg. If backline is recommended, maximum of 2 trials only. This is other neonatal bundle care of IVH, but I will not go through it. It is in detail or more than what I explained before, and we can review it later. Now, this case already presented by Dr. Hanan, and I took her permission to talk about it rapidly. This extreme preterm baby was delivered in our hospital, 815 gram, 25 weeks, delivered by emergency cesarean due to transfer lie and cord prolapse. Apgar score was 1 at 1, 3 at 5, and 6 at 10 minutes. Management at birth: golden hour applied, baby received in plastic bag, head cap, baby came severely bradycardic, required BBV, heart rate started to improve but no spontaneous breathing and no respiratory effort. So intubated, caffeine given in OT, then started an IV fluid. After stabilization of the baby, shifted to an ICU, connected to ventilation and received Servanta. Now I will go directly to case analysis because all of us already know this case and attended the previous lecture with Dr. Hanan. So that baby, the leading cause for severe IVH was the patient condition fluctuation, extubation, reintubation, anemia, required blood transfusion in the first day and on the third day, high blood pressure during the first transfusion above 95th centile, multiple additional volume replacement, fluctuation in blood gases from metabolic acidosis to next then respiratory acidosis with short period of time, persistent metabolic acidosis requiring extra volume replacement, BDA, multiple suctions, disturbance in coagulation status requiring FFP and vitamin K, disturbances in hemostasis requiring albumin infusion, handling, assisting by new nurse, so the staff that was unaware about the interpretation of ventilatory setting and patient. That baby unfortunately died, and thank you so much.
Thank you.
Any question?
Floor is open for any comment or any question.
مرحبا. كيف الحال? Just my question is, are you practicing delay cord clamping? Sorry لأني لحقت على آخر المحاضرة.
Delay cord clamping, yes, we are practicing, but sometimes according to the gynae obstetrician, we are trying to interfere with them and to apply the delay cord clamping mostly.
Provide the baby is steady
Yeah, yeah.
to have that cord clamping delay.
Because delay cord clamping for 30 seconds or 45 seconds, it will give good stabilization, hemodynamically stable patient, because it's just like you transfuse him with extra blood. And this is really showed reducing the IVH, especially grade 4 and grade 3, because the baby will be more stabilized, no hypotension. And really, for us, we discussed the DCC or delay cord clamping before any cesarean or any delivery, if there's any contraindication. If there's no contraindication, we try to practice this one, especially for the babies less than 36 weeks.
Yeah, okay. This is the breast. Yeah, this is good. Even us, we
Provided
are
the baby
we are
condition
doing
allows.
something.
Baby is still in this condition allows. And the good point is here, Asma, when you mentioned that it is not always progression that grade 1 to 2, 2 to 3, 3 to 4. Sometimes from grade 1 you can go to grade 4, which is the infant part. So it's not always a sequel. Sometimes you start as a grade 1, when you repeat the brain ultrasound within like another 3 days, according to the percentage you have presented, that IVH will see 50% to day 1, up to 80% to day 2. By end of day 7, 99.5 already start. So after day 7, it is very less incident to have a new IVH if it was not from the beginning and progress. Sometimes from grade 1, you can then go to grade 4. You can add IVH and far related to the EHSUAE area where the blood supply will be صار في عندي hemorrhage combined with that hemorrhage infarction in this area. Which will end up like a presentation of a flare أو نسميها big Malaysia. Flare presentation على ultrasound finding.
Any more questions? Comments? Any more questions or comments or?
Again, I will comment on Rola. I think Rola, she's the one who was saying about the ultrasound. Usually, we are not doing ultrasound in day 1 or day 3 because of the IVH bundle. So we do it by day 5 or day 7. Most likely day 7 because it, as she said, it will be more accurate. Unless it's really indicated like severe acidosis or unexplained anemia, and I want to answer why he's that. But otherwise, with IVH bundle, no head ultrasound in the first week of life.
Actually, for our practice, we are not doing the brain ultrasound for the first 3 days only. After that, we can screen for the IVH. But unless, as you said, the baby had rapid, unexplained drop in the hematocrit anemia, we want to search for the cause, so we are doing before the 3 days.
Hi, good morning. Yeah, go ahead, please. No problem.
Thank you, Dr. Yasser. Just speaking with Dr. Amna, because our protocol here, Dr. Amna, after we have reviewed many literature for the brain ultrasound for baby under care bundle for IVH, because a lot of discrepancy and a lot of opinion between different people. We were doing it on day 3 after finishing the care bundle, but we found that some baby, we need to do it early, as you said, especially if the baby had unexplained metabolic acidosis, we had large PDA that may be associated with IVH, or the baby presented with severe anemia. In those cases, we need to rule out the IVH at that time. So I think the practice is a little bit different from one institute to other institute. But here we are doing it on day 1 of life, so we are making sure that this is not related to the perinatal effect itself, or on day 4 after just finishing the IVH bundle. So this is our practice here, Dr. Amna and Dr. Muna. She agree about it, and we are adopting it in our unit. I don't know what about Dr. Yasser.
Yeah, I agree with you, Doctor. And then this is what really we are doing. Unless it's indicated, we never do head ultrasound. The other things, what I want to comment on it.
هي صحيح. ما ينفعش تتحكمي فيها.
Dr. Amna, you are silent. Can you just unmute yourself, please?
Yes, sorry. Sorry what I want to say. So احنا on the IVH bundle we are I don't know Dr. Yasser is around or not. I think he wants to ask one question.
Your voice, Dr. unclear.
That's quite good.
Dr. Yasser, can you please go ahead?
Yes, hi, good morning, everybody. Just 3 points. The first point regarding the head of the sound in the first day of life. I don't think it's a big interruption for the bundle, for bundling the baby to do head ultrasound in the first day of life. Like one of the best bundles I've heard about in Calgary by Dr. Khorshid, and they do head ultrasound in day 1 and day 3. And even they do it in more extensive than what we're doing in very more detail. So I don't think it will be that much of harm if you put a probe for 1 or 2 minutes and just figure out what's going on in the ventricles in the first day of life. And probably I will refer you to this very, very nice bundle done by the group of Calgary, headed by Dr. Khorshid Mohammed. It's everywhere, this lecture, even in YouTube. The second thing regarding the delay cord clamping, I agree also with Dr. Anna, and it's not only for preterm babies. I think we're supposed to do it up to 36 weeks of life, and even for the term babies, and with no milking, of course. The third thing for this presentation, I will elaborate much more on your on the details of your bundle after this nice summary of the IVH presentation and session. Thank you very much.
Thank you, Dr. Nasser.
The 2 main forces for the IVH are the flow and the pressure. So difference in the flow and difference in the pressure are the main contributing parts to have this IVH happen. So everything that affects the flow or affects the pressure intravascularly is the ones are the forces which cause the IVH.
Small comment. The last baby that's having IVH grade 3 or 4, the case presentation, intubated, extubated, and re-intubated again. The risk of having IVH with re-intubation, the patients, it's increasing by 40%. So that's why we, as much as we can, if we extubate, try to go with the criteria of readiness. The baby is ready for extubations, and then not to re-intubate it again, because each time we re-intubate is giving high chance of increasing IVH.
Yes, you are right. Dr. Khalid, can you, I think you raised your hand. Can you share us what you want?
Dr. Khalid, تفضل.
Can you clarify further regarding time to then ultrasound? Thank you. Have a good Dr. Khalid.
Yeah, already explained by Dr. Mohammed Abu Saif,
Yes, Dr. Yasser.
and Dr. Yasser also.
And there is a different practice in different institutes. So yeah.
No more questions?
Thank you.
Thank you for
Thank you
all.
so much.
Yeah.
Thank you. So we can conclude the
Thank you.
meeting.
Have a good day. Thank you.
Thank you. See you next week, inshallah.
مع السلامة جميعا.
Thank you, Asma.